So Southcentral Foundation is just part of how that plays out in Alaska. We're one example. It's a regionalized healthcare system, the tribal healthcare system. And the South Central region, or the Anchorage Service Unit, is the blue area in the bottom of the map with the lines through it. It represents 65,000 Alaska Native people, 55 villages, most of which are not on the road system. We operate with our hub communities in Anchorage and the Mat-Su Valley. And then we directly deliver care in something like 20 small villages, and we provide regional support to more than those. So it gets a little bit specific about how healthcare plays out in all of those places, but that gives you an idea of who we are in the bigger picture of the tribal healthcare system. The other thing to know is that in addition to being a regional healthcare provider for 65,000 Alaska Native people in our state, we happen to be located in the hub community for the entire system, where the centralized hospital that serves the whole system lives. And so we are partners with ANTHC, and we co-own and co-operate the Alaska Native Medical Center. And the Alaska Native Medical Center is a location or a partnership between SCF and ANTHC that serves two purposes. It delivers the local and regional care for the Southcentral Foundation area, and it serves as the statewide hospital hub for emergency, inpatient, and specialty care. So next slide. And I know everybody here has vision and mission statements where you work, but this is really important to understanding what we're about. So I want to spend just a minute on it. Our vision is a Native community that enjoys physical, mental, emotional, and spiritual wellness. And if you could just sit with me for a minute in the idea that Western medicine for far too long has focused on the physical wellness of an individual. And we think that our wellness, and I mean like literally me today and you today, is a balance of how we're doing physically, mentally, emotionally, and spiritually. And that those things are, they're interconnected. You can't separate them. So it's not okay to say, oh, good, we're doing physical health care over here, but don't worry, we have behavioral health in that corner over there for that one uncle in your family. That idea that you would separate those services, it doesn't make sense if you understand that each of us actually have this balance of physical, mental, emotional, and spiritual wellness. And if that is the core of how you think about wellness, then it changes how you design a healthcare system. And that's been sort of foundational in developing this Nuka system of care. The second is our mission. So it's how we walk towards that vision. It's working together with the Native community. And the key word there, just to go back one second, is this idea of working together. So in healthcare, typically there's this hierarchy between healthcare system, healthcare experts with all of our initials behind our names, and patients or recipients who come in to get that healthcare. And our orientation to community is intentionally different than that. And so our goal is to work together with community in order to deliver the healthcare system that community tells us that they need. So the word together, partnership, shared responsibility, and relationship are the way that we do the work. In fact, we would say that the core product of our healthcare system is not diagnosis or treatment plan, it's the quality of relationship that we can sit in at a macro level between system and community, and at a micro level between care teams, people, and families. And it's the nature of our work. It's how we get to our vision, is this idea of sitting in relationship with each other. Next slide. We have sort of a set of principles that guide what we do, goals being the values, operational principles being the voice that our customers have given us about what matters to them, and core concepts being how we expect it to feel when you work here. So I know that Doug's going to talk a lot about the service delivery model, and a lot of people want to understand sort of the nuts and bolts of how we deliver care. People come up and to learn about advanced access and integration of these things, but I would push us to remember that the main thing we're doing is giving power to community, because families know what's best. Families know what matters in their wellness. And then being responsive to the voice of community as they drive our healthcare system. So next slide, we intentionally use this word customer owner as a way to describe our relationship between the healthcare system and the people and families who we work in partnership with. We don't say patient or client or member because we think it reinforces that hierarchy in healthcare. And we're really looking to rebalance that. So I would say to a nurse or a doctor who has all of that education experience, thank you for bringing that to your work, right? We want you to bring yourself and your experience to it, but we want you to sit in a relationship with the person or family and to acknowledge the expertise and the experience and the wisdom that they bring to that relationship, and to see that happening really in partnership together, not hierarchy, but relationship. Next slide. I have just two more kind of foundational slides. So we really believe that the key to how we intend to partner in real time with families towards their own goals for wellness is through the quality of relationship that we sit in. And if we can really develop that competency of sitting in relationship, then we can be a true partner in tackling the things that actually happen in our lives, where our choices and behaviors lead to our wellness. And we work really hard on building that competency of relationship in order to get to wellness. Next slide. And we push ourselves as healthcare to acknowledge that we might think we know what's best, but we are always going to ask community, and that we're going to create ways throughout the fabric of SCF for the voice of community to be what drives us. And that's actually, it's really hard to do in healthcare. A lot of places say they get community voice, but it's like a check the box that happens maybe once, some sort of survey. And for us, it's the business of healthcare. It's the action of leadership to be actively putting yourself in a position to be directed by community. And it takes intentionality to design that as the way that a system operates. So next slide. I think what's really important about our system is that in the beginning, our leaders at the time spent active time listening to customer owners about what they wanted as we were transitioning from federal operations to tribal. And next slide, why people come to look at our story is because we didn't just tinker around the edges or do some improvement work. We really did whole system redesign, and we're willing to walk away from the model that we knew didn't work for community and build something new. So with that, I am going to pass the philosophy portion, although I know Doug's going to talk philosophy too, because we can't stand it, to Doug so that he can talk a little bit more specifically about kind of how that plays out in designing our clinical model.
So I have 3 more philosophy slides, and any of you who have heard me speak in the last 20 years, some of this is probably familiar because it is what I understand to be the basis of what Alaska Native people have said to us is important for us to understand. And they're the slides that we use when medical professionals come to work for us, that I use to explain to them how their work life here is going to be fundamentally different than their work life before they came here. So next slide, back up one, there you go. So this is the fundamental basis, which is, as I put in the chat box, just becoming customer owned. So just to clarify, moving to a single payer system, which is what a lot of people think is the panacea, or moving to customer ownership, neither one of those inherently changes the system. They provide opportunity to change the system, but they don't necessarily change the system. And we're big fans of both, big fans of comprehensive payments and of customer ownership and customer driven voice. But really, the issue is changing medical culture and changing the medical model and challenging a lot of the assumptions. And too often, self-determination and customer ownership has resulted in changing the corporate office and the financial management, but medical practice has still primarily been left to the medical people. And that's what's different about us, is the Alaska Native people owning this part of the system said, no, we want to be in conversation about the actual assumptions of the medical model and the actual way modern medical miracles are delivered in support of Alaska Native people. So this is the summary slide. Medical culture, and April basically already said this, medical culture and the assumptions and structures of modern medicine have been replaced or reshaped by basing instead on relationship, shared responsibility, customer ownership, story, and if you want to put it in academic terms, something called the complex adaptive system theory, which has been around for decades, but is relatively unknown in healthcare. Next one. So just to illustrate the fundamental premise, I have two slides. First, the story version, which is the rock and the bird. So if in our work, and again, as was said at the very beginning of this meeting, this whole topic is sort of focused mostly on chronic conditions. And in case you don't know, around 70% of the money spent now in healthcare is because of chronic conditions. So about a third or 30% is around acute things, trauma, injury, and all the things that come with that. But 70% of the money spent in healthcare now is because of people living with chronic conditions and the exacerbation or deterioration of those chronic conditions. So the business we're in of walking with people over time drives now the majority of the money and the majority of the employment and cost of modern medicine. So it's not just a little thing off on the side, but we would separate that. We would say a fair chunk of what we do in healthcare is a manufacturing industry where we do things to people. And that's what I'm going to illustrate here. So this is the analogy from complexity science. If I stand and in front of me is a target at some distance, and the goal is to hit the target. If I have in my hand a pile of rocks, over time, I can eventually make those rocks hit the target every time. The rocks are passive, I'm active, I'm in control, I control the variables. I can learn from really good rock throwers. I can benchmark and best practice. I can standardize and protocolize my approach, measure the wind, have people supporting me, and eventually I can make the rock hit the target every single time. But if I have in my hand a bird, and for the smart Alex, it's a live bird, and the goal is for the live bird to get to the target, I can push that bird with a lot of force and it will start heading towards a target. But as soon as it's out of my grasp, who decides where that bird goes? The bird. And it's going to go where it is most interested in going. So if the target is of great interest, it will go to the target, but it might get instead distracted by a place it likes to sit. Like this photo here has the bird sitting on a wire, telephone wire or something. But it might go to food, it might go to its babies or its families, it might go hang out with other birds rather than go to my target, which is not of particular interest to the bird. So in healthcare, if we go to the next slide, you can show this in a graphic version with this, which is a control diagram, two variables, the healthcare system and the patient and family, or as we prefer to call them, the customer owner and family. And there's only two variables and it's percentages. So one is the inverse of the other. Together they add up to 100%. And this is the same thing I just said briefly, which is in the high acuity environment, the system has control. The medical people are in control. So if I get hit on a sidewalk by a car, the EMS people scoop me up and do things to me. The ER does things to me. The operating room does things to me. The intensive care unit does things to me. That's a high acuity environment. The patient is passive and the system is doing things to them. So that is a manufacturing style platform. That is where standardization and protocols ought to be in place and variation ought to be driven by my medical variables, not by the opinion of the provider. And there's been a huge amount of progress in modern medicine in this area in the last 25 years through patient safety movements and standardization, protocolization of lots of things. But 2/3 or 3/4 of healthcare is not that. It's driven by people living with chronic conditions, diabetes, high blood pressure, congestive heart failure, depression, anxiety, a whole HIV, a whole long list of things. And in those settings, we're on the left side, which is lower acuity. And in that setting, the customer owner, the patient, the family, they are in control. Not whether we want to give them control, they always have been and continue to be in control. So let's use an example of a 55-year-old with diabetes, and I'm their primary care provider. They come and see me, I give them a diagnosis, a treatment plan, I prescribe some medication, and they leave my presence. And what happens from then on is under their control. Whether they even pick up their medicines is up to them, and surprisingly, not everyone does. How they take those pills is up to them. If they've been to 5 different specialists and have 5 different care plans and 25 prescriptions, how many of those they get and how many of those they actually take to optimal effect is under their control, as is everything else. So things like alcohol, tobacco, drugs, exercise, nutrition, how they handle frustration and anger and so forth. All those things, exercise, sleep habits, all those things are under their control, and they drive between 80 and 95% of whether or not they deteriorate and how much they cost us and how often they end up in our hospitals. So it's not whether we're going to give them control. They have already had control in this setting, right? So 1/3 of healthcare, high acuity, manufacturing, it's like throwing rocks. We control the variables, we drive the costs and everything. But 2/3 is a service industry model where they are in control. And the question is, how are we going to influence them to do something better and healthier than they would have done had they not encountered us, including picking up their meds, taking their meds, and all of that kind of stuff. So this is fundamental to our whole approach because it means we need to adapt to them. It means we have not added value to this equation if they don't do something different after encountering us. And just giving them a diagnosis, treatment plan, and pills is not enough. That's the beginning of the conversation. But what they do with those is the actual impact, which is back to April's point. Through relationship, it's how much we can influence them to do something different and better after encountering us. So our core skill set has to be about influence. So motivation, respect, education, encouragement, cheerleading. And at least in medical school for me, I was not taught a whole lot about how to do those things. And I don't think I was selected to go to medical school for my ability to do those things. In fact, kind of the opposite. I was selected along with all my peers to go to medical school based on how well I could sit alone in some room and memorize stuff to put on a test, which means I'm probably, by definition, not the most skilled person at, the people that are really good at influencing each other were down in the bar down the street having a good time with each other, as opposed to all of us nerdy people sitting in a room memorizing crap for tests. So we have a problem with how we get medical professionals. We have a huge problem with how we train them. And then we have an even bigger problem in the system that they work in, because the system they work in is antithetical to doing this work well. All right, next slide. So what have we done? We've spent 25 years recreating our entire system. And again, today's emphasis is chronic conditions and all of that. So it's what we're going to emphasize, although there's a lot more to our system, and we'll mention some of that briefly. But what we did is over 25 years, we've come up with a particular delivery structure. And that's what I'm going to describe. Not so much the journey of how we got here, although there's time to talk about that in the question and answer time if we can. So where we are now after 25 years, the customer, owner, and family are in the middle. They choose a primary care provider. And we try to impanel, which is, the panel is how many people does a primary care provider have that have chosen them. So we impanel to one primary care provider. Everyone has one they choose. And we try to do it by extended family and extended household. So if there's 25 family members and grandma moves in from a village, she gets the same provider no matter how full that panel is, because relationship and context of whole families and households is extremely important to our whole philosophy. Life happens in a context, not in isolation. Life happens in reality, influenced by people around us, not just in an exam room. So we have these panels people choose. At any given time, half of our panels are open and half our panels are closed. So the fullest ones are closed, except never closed to additional family members. But half are always open. So people always have the choice. There's male, female, there's all kinds of different variations. There's big bios and so forth, and people can choose who they want. The default is family or household, but if you want to be separate, you can be separate. So if you have a lot of private health issues and you want a little distance from your family, you can choose to do that, but the default is the whole family and household. All right, the people you're in intimate relationship with then are the primary care provider. Every primary care provider has a nurse case manager And almost all, we now have hired so many behaviorists that there's also usually a pretty well identified behaviorist. So your relationships to a primary care provider, case manager, and behaviorist, and supported by CMAs when you come in for a visit, and CMS is case management support, which are helping the virtual interactivity in support of those people you have the intimate relationship with. And then we right size our clinics. So we don't have big, huge sprawling clinics. That is too impersonal, both for the people working there and the people coming for visits. So like in Anchorage, in our big primary care center, we have 9 separate primary care clinics. So we right size for efficiency and cross coverage, but still small enough for the feeling of intimacy and personal connectivity and so forth. So every one of our clinics has 5 or 6 primary care provider teams, and then physically located with them and available to help them do their work all day long, every day. So fully integrated with them is a clinical pharmacist, a dietitian, a couple of midwives, a social worker, and as already mentioned, behaviorists. And so that's in every clinic. There's plenty of those for everyone to have immediate access anytime they want or need them. And then located in the facility, physically in primary care, but more co-located, not quite as fully integrated, are a whole lot of other people, because the idea is we pull expertise to where the person is instead of sending them around to a lot of centers of excellence or specialists. So also co-located in primary care, whose sole purpose is to support this work, are a bunch of psychiatrists, HIV expertise, complexity adult expertise, complexity pediatric expertise, lactation expertise, and then a fellowship trained physician in chronic pain, a psychologist with over 30 years expertise in chronic living with pain, persistent pain, physical therapist with particular persistent pain expertise, and then another palliative care fellowship trained physician, and a team of people that help that palliative care person, and then a whole range of home visiting people that are extenders who can be going out into the homes. And all of this is available to the individual and the family on a guaranteed same-day basis. So for over 20 years now, you're guaranteed same-day access all day, Monday through Friday, to these people. So immediate same-day access, and however you choose to connect. You can choose to come in person for a visit, but you can do phone, email, text, video, however you want to connect is acceptable. And even before COVID, left to their own devices without a lot of external meddling, these relationships had evolved to be primarily virtual. So about 30 to 50% of the interactions were in person in an exam room or a talking room. But over 50%, anywhere from 50 to 70% of the interactions in any given day were text, phone, email, however the person wants to connect to us. So the whole approach is we have expertise, services, and products that they want or need, and we weave it into their lives on their terms. So we build relationship, create intimate connectivity, and then facilitate that through however they want to connect to us. And it ends up being more asynchronous and more virtual. Because think about this, if you make people come for visits every single time, they have to make an appointment, then they have to wait, then they have to take time off of work, and they have to come across town, and then they sit in our waiting room, and then they see us. And then generally only get like a very few minutes with people who basically tell them, here's your diagnosis, here's your plan, here's your medications. And then when they don't do exactly what we tell them to do, we judge them non-compliant in our extremely paternalistic, judgmental, harmful, institution and professional centric way, which is completely unacceptable. And sorry, I lost my train of thought. I glanced at the chat box. And so instead, we need to change that to be, we build relationship, we get to know each other very well, and then we make ourselves available. So if you've done all that effort for an appointment, made an appointment, come across town, got daycare, taken off of work, it takes a half day to have an appointment. By the time you see me, you have very high expectations for this encounter. So I better order you some labs, some x-rays, some medications, because you invested a lot into this encounter. If instead I'm available by whatever way you want to get a hold of me, and we have trusting relationship already in place, then the person on the receiving side is much more willing to try a few things, to adjust a few things in their life, and not demand lab, X-ray, and pharmaceuticals immediately, because they have much less invested in the conversation. And they know if things don't improve, they can get back to me again later today or tomorrow or whenever they need to get back to me. So both less effort on the front side and guarantee of connectivity whenever needed means in the end, we end up having people demand way less from us in terms of lab, X-ray, pharmaceuticals. And we order way less of that stuff because we instead have relationship conversation, try this, and maybe that will help before we get to the big guns of lab, pharmacy, X-ray. So we order way less lab, way less pharmacy, way less radiation of people, and way more advice, partnering, cheerleading, supporting, and that kind of stuff. And we pull all the expertise towards us. So instead of sending you to 5 different centers of excellence, instead it's all pulled towards you in support of you. So remember, psychiatry, persistent pain, adult complexity, pediatric complexity, palliative care, all provided physically right in primary care when you need it. And then on the outside circle are these kind of purplish people, which are the specialists who are still somewhere else. So the cardiologists, the pulmonologists, the so forth, rheumatologists, ophthalmologists, they're still in their clinics. But because we've created this massively powerful primary care, they're more willing to join immediately virtually rather than demanding a visit to their office. And because we are a whole system and we pool revenues and we manage costs at a global level, they're also more willing to just jump in and provide advice and support to the hub rather than demanding that everyone come to their center of excellence and then they repeat lab, X-ray, and order more pharmaceuticals and all that sort of thing. So the entire outpatient system is reoriented around intimate relationship, immediate accessibility, and then pulling expertise into that hub. So you move away from disease-specific approaches and institution-specific settings and all of that kind of stuff. Next one. So this is just a list of the ratios of people in that setting. So I did this kind of verbally already, but just a graphic to go with it. So there's around anywhere from, we're right around 1,000 to 1,100 people on a panel. And then each of those primary care providers also has 1, 2, or 3 villages. So they're doing urban work and they're also supporting remotely, very remote populations in villages. So every primary care team has 1,000, 1,100 individuals locally, another several hundred in remote villages that they support. And their team is, the ratio is primary care provider, case manager, case management support, and CMA as the intimate team. And then shared among 5 or 6 of these teams are 2 behaviorists, a pharmacist, a dietitian, generally 2 or 3 midwives, and then some coverage people, PAs and nurse practitioners to cover, so that if April and I were both primary care providers, when she's out, I don't have to see her people. And when I'm out, she doesn't have to see my people. I see my people, they see me, and there's coverage people that step in when I'm on vacation or whatever else. And to be a primary care provider team, you have to be available all day, every day, 5 days a week. We don't have only sometimes available people. And we do coverage things so that every day there's hours into the evening, and all day Saturday there's access as well. Not necessarily to your primary care provider, but someone who works with them. All right, next. We've done a ton around physical space design in support of this. So nobody has a private office. There's no doctor's lounges, there's no doctor's offices, there's no doctor parking spaces, and everybody sits together. So the intimate team, the case manager, primary care provider, CMA, CMS, they sit right together, but then scattered among them are all the other people, behaviorists, dietitians, pharmacists, psychiatrists, all of these other people. And it's all line of sight, so everyone can see everyone. Again, we've right-sized the clinic so we don't get too much of a mass of humanity. And we've done a ton of intentionality around physical space design, and that's a whole nother conversation. But we've done a lot of work on dampening sound and all of that kind of stuff. And we had lots of headsets and headphones and so forth, so that there can be private conversations, but still in the shared space. When people really need private spaces, there are an array of rooms. So there are what are called talking rooms that are carpeted and you sit and talk with someone. Those are right outside the team space. And then there are what we call hybrid exam rooms that have both a talking room element and an exam element. So with an exam table and such things, but also sort of a talking room capability. So you don't have to use that exam table unless you really have to use that exam table. So it's all laid out. So lots of private spaces if you need private spaces, lots of medicalized spaces if you need them, but also lots of spaces where respect and honor are maintained and you're not naked sitting on an exam table if you don't necessarily have to be. And I already mentioned all the co-located specialists. I don't have it, doesn't look like we have a slide today with that, but again, to repeat, psychiatry, persistent pain, palliative care, adult complexity, pediatric complexity, HIV, and then a whole array of home visiting people. So it's when people look at us, they say, well, Doug, you guys have like the world's most expensive primary care system. And my answer to that is yes, if you count the budget of all those people located in primary care. So yes, the amount of money spent on human beings being available in the primary care setting is massive. It's a huge amount of money, but almost all those people were already in the system and have just been relocated. The psychiatrists were in the system. Palliative care was in the system. The adult and child complexity people were in the system. The HIV expert was in the system. They've just been relocated to build things around the customer owner and that intimate, trusted relationship with that primary care team. In that whole setting, really the only people who are a pure ad are the behaviorists. And there's a ton of them. We've got like 50 of them. PHCs or behavioral health consultants. They're pretty much a pure ad because we still have behavioral health clinics. If you need long-term psychotherapy, unpack your life, unpack your childhood, that's still a destination. You still go to the behavioral health clinic and you engage in that long-term work. But the brief behaviorist-based intervention, and they hate when I say this, but I call it the hairdresser bartender version of behavioral health. So behavior modification stuff in primary care by behaviorists, that's pretty much a pure ad because that didn't really exist in the system previously. Otherwise, it's redistributing people. So yes, when you look at the budget, it looks like a lot, but it's just been basically moved around in the system. And the total cost generated is actually low because if we order way less lab, x-ray, pharmaceuticals, and specialty referrals, the costs generated by primary care are way down. So all of this is done on a per capita spend of about 2/3 the national average. And our primary care is inexpensive in terms of costs generated out of primary care, but it is expensive in terms of humans placed in primary care. But you got to understand all of that because people look at this and it feels daunting, but really it's rearranging the pieces of the system, not really adding huge new costs. All right, next slide. So April already mentioned this, but this is all circling back around. This is still the fundamental thing. They're on their journey based on those slides and the rock and the bird analogy I showed earlier. They are in control and we are adapting to them, listening to their story, understanding their motivators, their values, and all that sort of thing. So like with the 55-year-old diabetic who was seeing me, if I just tell him about his hemoglobin A1C and I give him a bunch of directions and here's some pills, that's not a lot to motivate him. But if I can tie all of that to things that matter to him, so if he's a 55-year-old Alaska Native man in Anchorage, probably he's first or second generation in from a village, he probably likes to hunt and fish and berry pick with his family, and he likes to teach his grandchildren these traditions and take them back to the village and teach them hunting, fishing, berry picking, putting up the food for the winter, and the cycle of life that Alaska Native people are still very connected to in Alaska. If I know that, and I can talk to him about maintaining his eyesight, his fingertip sensation, and his toe sensation so he can hunt, fish, and berry pick for 10 more years with his grandchildren and teach them these things that are very important to him by controlling this thing called diabetes and hemoglobin A1C, now I have tied my target to his values and his goals that are most intimately important to him. So that's me understanding him, his motivators, his goals, and moving my target to where he already wants to go instead of trying to coerce him into some intangible way of understanding my target. So we do what's called tight, loose, tight management, where we obsess about philosophy, we obsess about outcomes, but then we give our staff and our teams a huge amount of flexibility for how they organize their minute-to-minute work, their day-to-day work, their teams, how they connect, how they motivate, and so forth. And then we track their outcomes. And the best people we go learn from, and then we spread those practices to everybody else. But it's a completely different understanding of the business we're in, a completely different skill set, and all about adapting to them, what matters to them and motivates them in their context, their lived history, and the people around them. Next. These are things we're working on right now. So we're fully integrating all children into all ages clinics, and we're moving our pediatricians and pediatric case managers into all ages clinics. So from a parent perspective, no longer do you have to choose between your family PCP and a pediatrician. They are one and the same. They're in the same team and in the same location. It's no longer a stressful choice for parents to make. We have built in the ability to handle incredible amounts of complexity in children in those teams in primary care. We have this whole huge project right now called New Generations, where we are intensely intervening on teaching and modeling parenting and creating things called parent partners, redesigning the whole way prenatal, birth, and immediate postnatal care is done to be a single conversation using the same words, the same models. We are tripling the amount of time we spend with people while pregnant and in the first 2 years of life. We have a huge initiative called Aging Well, starting at age 40, connecting with people about predictable things that happen as they age, and then partnering up with them in much more anticipatory and effective ways from age 40 all the way to death. This huge thing called Aging Well. We've given now thousands of people, soon to be tens of thousands of people, wearable devices from watches to blood pressure cuffs to scales in their homes. We've now paid for and developed our own app to receive all that information and feed into our platform of communication with people. We continue to expand all the ways we get into people's homes and not just make them come to our environments. We continue to do a ton of work around addictions and persistent pain and palliative care, advanced directives, and all of those things that are where the majority of cost and health complications occur. And then continue to work at this balance of asynchronous video, text, email versus in-person visits, and really do it on their terms. And if you look at all these big projects, none of them are physician-centric or institution-centric or office visit-centric. It's instead seeing health as a journey and a context and weaving a web of connectivity and services into their lives on their terms. Next. So this is another little diagrammatic thing about how we think about work. In the usual medical office, everything goes through the doctor, and it's called a rate limiting step. The whole system can only move as fast as that one person can move. And whether you're in manufacturing or in healthcare or anything, it's a bad plan. Having a person everything has to go through is a terrible plan, especially if you have tons of other very skilled people around you. So next slide. We instead want to do parallel workflow design. So this is again true in manufacturing, lots of other places. If you can have lots of people working as teams, each knowing their part and how they connect and relate to each other, and not make it confusing for people on the receiving side, with the same number of people, you can double or triple your productivity because of redesigning workflow and being much less professional and institution-centric and doctor-centric in how you design services. Next. This is just a picture of our campus. To remind people from what April showed also, we went from a very hospital-centric, sort of old style, you come to us kind of approach to much more of a friendly spaces, dignity, honor, respect. It turns out that self-confidence is what primarily drives health outcomes. So back, they're in control. And it turns out the more you do to life, the better your life goes, the better your health outcomes, the better your educational attainment, the better your employment, the better your marriage, the better your children, the greater your happiness. Higher self-confidence, better life. Lower self-confidence, life does to you. And then just things happen to you, and it's not generally very good. So core to our business is raising the self-confidence of every person, every family, and Alaska Native people as a whole. So part of what we do is our facilities, our spaces are beautiful and welcoming and pride instilling and pride raising. When we opened our beautiful clinic in the Matsu Valley, Alaska Native elders wept openly and said, we've always been here, but now we can be seen. Now we can have pride. Now we have an identity in this community where we live in Wasilla and Palmer. In Anchorage, there's a lot of tribal buildings, a lot of corporate headquarters, but in the Valley, there was nothing until this beautiful building that's a gathering place, that's a celebration space, potlatches, weddings, funerals, all held in this community space that also is a medical building offering medical services and clinical services and so forth. So a huge amount to say about how you design spaces and campuses and ways people interact with us and so forth. Next. This is to reiterate what April said earlier. Massive investment in behavioral health. And April, prior to becoming our CEO, was our VP of behavioral health for a bunch of years, became very influential across the state in behavioral health policy and helped us greatly expand what we do in kind of the whole behavioral health space. But really, when we talk about primary care, we are merging behavioral, medical, oral health into this thing called primary care. It's not medical primary care, it's person generalist primary care in all these different dimensions. But as part of what we've done is build a fabric of what's usually called behavioral health. So in addition to tons and tons of behaviorists in primary care, you have psychiatrists in primary care as well. Turns out you can do triple the psychiatry work if the psychiatrist helps the generalist deliver the psychiatric work. Because if the psychiatrist does everything, that's another rate limited step. If they facilitate other people, then that opens up capacity. And psychiatrists are hard to come by. So the way we do psychiatry now is very different and way more effective at much greater scale without having to hire a ton more people. We also on here, it says talking circles, and that's another huge thing. At any given week, we have between 50 and 100 active talking circles. This is where people come with their lived experience and their personal lived expertise as someone living with cancer or living with diabetes or parenting teenagers and help share that with other people. So these are all set up, drop in, voluntary participation. Most of them, there's a few closed groups, but mostly open. And we have professional staff trained to help facilitate, support, and make the most out of this lived experience, expertise kind of thing. Like I said, anywhere from 50 to 100 at any given time that are active in our system. And then there's a lot of other things we won't go into so much today unless there's questions. Family wellness warriors trying to break cycles of violence, intergenerational violence, to break those and set up new ways of living healthily as families. We have destination mental health clinics. We run the only big medical detox program in Anchorage. We also do a ton of outpatient addictions work, the 4 Directions program, intensive outpatient therapy, a ton of Suboxone, both in primary care and with the psychiatrists and with the 4 Directions. And then a bunch of destination residential treatment facilities, chronic mental health things, what we call our Corona Clubhouse downtown. And we also are the primary operators of the clinics in the Brother Francis shelter and working with people experiencing homelessness as part of the Homeless Coalition. And that's been another huge effort that has a huge behavioral health and addictions component to it. Next. So just going to run through a bit of data and then I'm going to close out, and right on time, we're going to open up for questions, and there's going to be more than half an hour for your questions. So please, 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 let's get into conversation, challenge us, ask us, clarify, throw those questions in. And between April and Juanetta, we're going to get on all those questions. So we also have invested massively in a super capable data mall. So we extract all the information from our electronic health record and put it into databases that then we manipulate and control so that we can see and understand absolutely everything happening in our system. So just a few things, like here's breast cancer screening. The goal set by our board is the 75th percentile. So we use HEDIS, which is the National Database for Chronic Disease Management, Wellness, Prevention, Screening, all that stuff. And we benchmark against those national benchmarks. And we started out in the bottom 5th percentile for everything because we have a complex, high-risk population. But our board said we don't want to just be average, we want to be above average. So our target, like the red line on there, is the HEDIS 75th percentile. And we're exceeding that. We're doing better than that. And that's our board's expectation. And pretty much with few exceptions, we only got a few left, but like 95% of HEDIS comparable measures were at or better than the 75th percentile, which is dramatic, radical change from 20 years ago. And over decades will completely change the course of health and health status among Alaska Native people. It's already working and happening and will continue to play out over the next few decades. Next. This is what's called a funnel graph. So this has every one of our primary care providers on the bottom, and it's a performance metric. I can't read the fine print, so whichever one it is, but the point is that it's got a dot on there for every PCP team, and the control, the 2 standard deviation stuff is the control limits above and below. The bigger your denominator, the narrower that becomes. The smaller your denominator, the bigger it becomes. So what you're looking for are the high performers towards the right side of this graph. And then those are your best practices you want to go be curious about and learn from, and then spread those best practices to other people. So again, tight, loose, tight. We want to re-professionalize our staff. More than anything else, individual pay for performance will deprofessionalize your professionals. It's a horrible idea. So tying people's pay to their measured performance turns them into drones doing what we tell them to do, and them gaming the system to get the bonuses and money they think they're entitled to. So you don't want to do that. You want to professionalize and re-professionalize everyone, from your CMAs to your behaviorists to your dietitians. You want them all rewarded as a team for their performance, and not individually. Here's what we tell you to do in order to earn this money. In the US, we think money equals performance. It's ridiculous. These are professionals. If you treat them, if you even further professionalize them by giving them autonomy and control, they actually produce way, way better. This entire system is self-reinforcing because they're accountable for all those outcomes. And then we don't have to tell them how to do much of anything other than the philosophy and sharing with them best practices, because it's a professionalizing process of humans doing the work, which is what you want, because then it all becomes self-policing, self-rewarding, self-recognizing. All right, next. It's just more data. This thing on the left is like all the different measures for one person. So a person has their own dashboard of like 25 measures, and are they green or red or whatever? And so using colors, again, numbers we're trying to achieve and so forth. So massive amount of use of data. This could be a whole talk in and of itself that we don't really have time for right now. Next. And then just to show impact, this is inpatient use, hospitalizations. Next. Emergency visits continue to drop over time, especially the low acuity stuff driven by decompensation of chronic conditions. Next. These are all like per capita things. And so as a big summary slide, we've dramatically reduced ER, dramatically reduced inpatient, greatly improved HEDIS measures, as I already mentioned, and then really high satisfaction levels by both people using the system and people working in the system. So we benchmark our employee happiness and turnover rates and stuff to national rates, and we do better than the national rates in healthcare. And then our customer owner satisfaction, we're especially interested in measures about whether they feel respected and honored, whether their confidence and self-management is getting higher, whether their culture, traditions, and values are being incorporated into their care plans and being respected. So it's not just, am I treated nicely, but rather how much ownership are they feeling? How much control are they feeling? How much respect are they feeling? How much are they feeling in control of their own health journey? And those are actually some of the most important measures that we have. So people ask us, how do we measure differently? That's the kind of stuff we measure differently. But we also measure everything else, screening rates and hemoglobin A1C control and hypertension control, hospitalization rates. So really the classic medical measures, most of them are good. We just add in these additional things in addition. So what's different is not so much how we measure, but rather how we approach achieving those things. It's the customer owner and control, context of family through story relationship, and then influencing them. Next. So just a couple minutes on money, because people always want to know this. And actually there's been some bad misrepresentation in Alaska about our money. And so just to set the record straight, the amount of money we spend, that we receive and we spend, total cost per capita for the usual bucket of what we're comparing to, we are about 2/3 the national average. So, Medicaid and Medicare are running from $12,000 to $20,000 per person per year. We do all of this for $7,000 or $8,000 per person per year in terms of basic healthcare. Now, additional things are dental, optometry, residential treatment. Those are additional things. They're not usually in the bucket of comparisons when you're talking about healthcare costs. So again, it depends what you put in to compare. And our point is not to be the cheapest. is to prove that with the usual amount of money available, you can produce a way, way, way better product than what modern medicine currently usually does. And it's disintegrated, non-connected, paternalistic, judgmental, professional, and medical-centric way. I mean, of all the things we do in society, the most institution-centric and professional-centric thing done to humans in our society is modern medicine. It's offensive, it's destructive, it's harmful, in addition to doing wonderful things. And we're not so much out to change the high acuity stuff. So how the miracles around inpatient cardiac care, orthopedics, surgery, trauma management, most of that's actually amazingly good. You just don't want to overdo it to people who don't want it, where advanced directives come in and such things. We're not so much out to change that. We're out to change the way we relate to people living with chronic conditions and the decompensation of those chronic conditions. So for us, about 55% of our money, so more than half of our money, is fee for service. We do a service, we submit a bill, we get paid. And that's a terrible way to get paid, in our opinion. Right around 40%, a little bit under 40% of our money is through the Indian Health Service. And it's appalling that this country funds the Indian Health Service at a per capita rate at 40% as compared to Medicare, Medicaid, or even the VA. It's the most horribly funded healthcare thing the government does. And Alaska Native American Indian people are actually the only people who are constitutionally entitled to healthcare from the United States of America through treaties. Nation-to-nation treaties that guaranteed healthcare is one of the things that was part of the treaty settlements. And yet it's funded at about 40% per capita compared to all the other payers. We make it up by billing Medicare, Medicaid, private insurance, and pursuing community health center money, philanthropy money, and so forth. So we get close to the same per capita as other parts of the healthcare system. Not even, we're still on the low side, but we're not at 40% because we combine all these revenue streams. But most of Indian country has less capability of doing that, especially if you're in a rural, remote place where there's a lot less employment, or if you're in a state that did not expand Medicaid. So it's time this government actually funds the Indian Health Service in a fair, reasonable, non-racist way. That's a whole tangent. And then the way we manage costs is at a macro level. We design and spend at a whole system design level. So every year we spend time talking about, do we preferentially put more money into behavioral health, into addictions, into persistent pain, or where do we put our money strategically? So whole system, whole population budgeting and thinking. No individual department gets to keep its money. No individual department is on the hook to produce a specified amount of money. Although we're not dumb about money, we have to be smart about finding ways to keep revenues sustained at a level that allows us to do everything we want to do. Personnel are told to do the right thing. They're not told to do things that make money. And that is a very, very different environment compared to most of healthcare. And then primary care, we already talked about fairly extensively, but the final comment here on money is around margin. The issue for profitability is margin, not revenue. But healthcare tends to think of their costs as fixed, and the only way to improve financial performance is increased revenue. Well, that's just ridiculous. There's so much waste in healthcare. If you give up 30% of revenues, but you reduce your cost by 40%, your margin actually improves. And this is a lot of what we do. By ordering way less lab x-rays and pharmaceuticals and way less specialty visits, we're actually giving up a lot of revenue. But we think we're saving costs faster than we're giving up revenue. And both us and our closest partner, the Alaska Native Tribal Health Consortium. So we do the primary care, outpatient, maternal child health, behavioral health. They do more of the hospital, specialty, subspecialty. We work together to be a vertically integrated system. We actually share revenues between our corporations at a macro level. And so we can think and plan as a whole system about strategically where we put our money. But because of how we practice, we give up tens of millions of money we could be making, but we save more than that by how we save over expenditures and overuse and so forth, which improves our margin. Both our companies do, moderately well financially. So doing this approach has not harmed us financially, and if anything, has helped us financially. But you have to think and act at a macro level, or it doesn't work. And healthcare has an incredibly difficult time understanding that. All right, next slide. So we're going to circle all the way back around where April started. and just remind you that this is what drives us. If you look at how how April, myself, and the 10 other most powerful people in SCF spend their time in any given month. If you look at our schedules and add up our hours, somewhere between 10% and 40% of all our activities in any month are in customer owner environments, getting their voice, hearing their voices, checking in on what's happening, hearing people who are unhappy, connecting to elders and people with titles. And we have somewhere between 10 and 15 advisory councils. When they meet for a half a day or a whole day. The first half of the meeting is them telling us what they're doing and what they're observing and what they see about us. And then the second half is us giving them reports and so forth. So everything's built around continual, intense obsession with the voice of the consumer, the voice of the customer owner in tons and tons of ways, and then responding to that. And we don't just go say, hey, what do you want? We go and say, hey, we've heard issues and difficulties with this and this and this. Here's things we think might make a difference. What do you think? What are your ideas? Or here's things we're trying. How's that going for you? Is that making a difference? So it's a nonstop, continual conversation, but in their turf, on their terms, with their agenda, and us receiving and responding, rather than them coming into our holy institutions to join our institution and professional centric processes. Most consumer councils are that way. They're made to come to our space on our time, an hour once a month or something. That's pitiful. This is a service industry. We must obsess about what's working for people, and we need to observe what frustrates them and not just ask their opinion, but observe what's working, not working, what's frustrating. What do we hear on the ground? What do our staff hear on the ground? And have that all continually drive how we change and how we change and how we evolve. After 25 years of this effort, we continue to reinvent and redesign, as I told you, in those projects that we're working on right now. And then the final comment is, we're in a service industry where the primary goal is to influence people. The people who know how to do that best are the people from that environment. So for us, Alaska Native Hire is a mandate if we're going to do influence and relationship well. And that's true for any organization. Every institution should be, if it's a service industry where we're trying to influence people, then your workforce needs to be the same as the community you're trying to influence as much as possible. So when we took this over from the government, about 15% of the staff were Alaska Native. We're now at or well above 50 to 60% of the workforce, and about 75% of the supervisors, managers, and leaders in the system being Alaska Native people. So increasingly, Alaska Native voices inside the system, as well as on the people receiving services. And we encourage all of our staff to bring that into the workplace. As you work here, you are a customer owner, you are a family member, and that voice is from you as an employee. We don't want to separate the personal life and the home life from the work life. If you're Alaska Native, you bring it all to the conversation all the time. So we look at how our committees are set up across the entire system, make sure that every committee has good representation, if not majority representation, of Alaska Native people, whether they're there as Alaska Native employees or Alaska Native leaders or Alaska Native community members. And with that, I will stop, give April whatever voice she wants to add, and then to your questions. And we've got about 25 minutes left. Go.
So Doug, I'll just say, it's just to the group, it's hard for Doug and I to figure out how to do this in an hour. When we do our Nuka conference, where we share our system with outsiders, it's literally 2 to 5 days. So I'm dying to dive into lots of things, especially if you know me, behavioral health, but let's just turn it over to your questions and how the group would like to spend the time.
Great.
April, I think it's important for people to look in the chat box, because you've already answered quite a bit in the chat box. So if people aren't looking there, please look there in addition to the verbal part.
Yeah, but there's several that we skipped, Doug,
So go, April, you're in charge of this.
No.
You and Juanetta.
Okay,
Yes.
I'll scan back to the chat questions. Let's start with Ralph, and I also want to invite everybody online with us. Feel free to turn on your cameras and join us in community. We'll take live questions as well, but feel free to just step in, and we'll go to a gallery view for everybody. All right. So Ralph, let's start with you and see if you have a question.
Let me circle back around to, the initial point about customer owners for the system. And it seems to me that the piece that external observers miss is that there's an enormous advantage to connecting customer owners to the system. And secondly, that the native health system has turned what was a disadvantage, that is serving a population that was historically separated from the rest of the population, to serving that population, having them identify with them. And I'm particularly thinking of the issue of that in healthcare, particularly when we look at the high users, we're talking about chronic management. One of the issues with high users is historically that they what is the word I'm looking for? They engage the health system multiple times. They go to the emergency rooms, they engage multiple providers because in our current system, they're allowed to do that. It seems to me that one of the advantages of the system that's been built here and the identification of the customer owners with the system is this long-term connection to the system so that long-term solutions are possible and that people don't go looking for solutions elsewhere. So I hope I've been clear about what my question is. That is there an inherent advantage in terms of dealing with these long-term chronic issues, and particularly that, that the evidence that there's a small percentage of the population that uses a very large amount of resources by this, I guess self-referral is the word that I'm looking for.
I'm going to speak a little bit to that, Doug, and then you can probably add to it. And I think we might say different things. So Ralph, I love that question. I'll start by saying that we get the concept of high utilizers. We don't use that word in our system. We don't find that to be the language that makes sense to us. So I would say that, we orient our system so that it works for most people, but we notice in our system where there are people who have many touches that are not supporting the outcomes we hope for them to have. And so when we see those high touch points that are concerning, right? Sometimes you see lots of touch points that are very, very good, prenatal care being an example. Then we want to think about how we can spend time orienting ourselves to understand what is the life situation and goals of that individual, and how do we need to reorganize our care delivery to uniquely meet that person's needs. And we have to recognize, one of the things Doug and I haven't talked a lot about in this talk is how much integration of care is appropriate to be delivered in the primary care setting. And when is there an intensity level that requires a referral where a different area of care becomes actually primary? And I want to use the Kiana Clubhouse program downtown as an example of that. So if you guys know all the news of all the years about what's happening at the shelters, right next door, nobody hears about SCF's Kiana Clubhouse program, right? It's a day facility supporting adults with persistent mental illness who have a high ratio of time spent and contact with a case management team, and as a result, a lot of stability. And so one of my things I get excited about sharing is of the 110 customer owners at Kiana Clubhouse who are on a leadership council and co-create and run the program with the staff, right? It's a clubhouse with a therapeutic overlay. At the start of the pandemic, like all but 4 were housed, right? And this is a population and a location that is because people are at very high risk of experiencing homelessness. And so we have actually reverse integrated medical care into the behavioral health environment, acknowledging that behavioral health is probably the primary intervention for that group of people. Similarly, we are investing in intensive case management, which is to say that there is a population who are never going to show up at 2 o'clock on Tuesday because that was what works in our schedule. But instead, we want to deploy a team of behavioral health oriented folks who can sit in real relationship with people who could be described as high utilizers, bumping around between, I'm looking at Preston, RED, your ED, RED, your ED. How can we do that? How can we orient our resources to walk with people differently from a behavioral health lens? Doug, do you want to tackle anything besides that with that question?
I've been typing in the chat box. I completely agree, support everything April said. I think that just to put it in, hardcore medical statistical words, 80% of the cost is driven by 20% of the people, 50% of the cost is driven by 5% of the people. And especially that 5% are often the least self-care capable and the least organized and structured in their lives. And so to expect them to conform to our institution-centric office visit-based approach, and somehow that's going to work, is ridiculous. And it drives all these medical people all across the world to talk, especially in the US, to talk all the time about compliance and non-compliant people, which are words that April and I completely hate. If you're going to use the word compliant and non-compliant, it ought to be about us and whether we're compliant or not compliant with them and what works for them. And the idea that we can't tolerate people who are 2 minutes late for appointments and they must always come to us in an appointment-based way, or we can't interact with them. And then we just give them 5 minutes. Here's your diagnosis, here's your treatment plan, and here's some pills. And by golly, you better do what we tell you, is a completely miserably failed model. So the example April gave of Koyana Clubhouse is one of the most powerful ones of people least self-care capable independently, but it's a whole range. And there's a ton of people, and like 80% of those 5% who drive 50% of the costs in healthcare desperately need a different way of connecting, seeing them, hearing them, honoring them, connecting to their goals, aspirations, and values. And modern medicine is completely incapable of doing that in its current structure. So this is not just a nice for people thing. This is actually driving. And there's this great thing. Mark Foster was the CFO of the school district for years and years. And he did this great study that showed across 15 years of time that every penny of increased budget going to the school district ended up paying for massively increasing medical costs for the benefits of all the people employed by the school district. So we, medicine, modern medicine, are literally stealing money from classrooms and children and law enforcement and firefighters and pothole fillers and snow removers by this incredibly crazy, massively expensive, failed system where 50% of the cost is going to spend on people for whom the current system is incapable of effectively connecting to them in influential ways. It's insane.
So let me take what Doug just said, and I'm going to introduce you one sentence because I have the optimistic stance, which is that I don't think we've realized the impact of this healthcare system we've created yet, because I think it's generational. So we have integrated master's level behavioral health clinicians on primary care teams who have compulsory contact with families over time, right? They're the ones, the BHC is the one who told me I was pregnant with that. What's that mean for you? I'm here for you. And I'm like, yay, hug me, we're good. But to be there in that moment over time. And so that means for my kids, they've never grown up in an environment other than to know that we're redefining what means primary, and that they have a relationship with behavioral health people to understand their emotional and mental wellness, so that my kids, hopefully, knock on wood, don't have kind of the life journey that we know actually will happen. But when they do, they already have connection. Because it's, as Ralph said, not incidental care, but longitudinal care with lots of touch points and relationships over time. But we should go to the next question. Be afraid of Doug and I when we start answering.
Well, I'm going to alternate back and forth between what's in chat and online. Just to go back to an early question from Preston about essentially the caseload. And I don't know, Preston, if you want to elaborate on that, but go ahead.
I'd be interested in terms of your team. So you have panel sizes that are roughly 1,100 to 1,400, and there's both Cs and touches within that. So the number of kind of customer owners that they see in an average day, and then the number of touches that entire team might do an entire day, knowing that that might be, like you said, around the chronic disease management is influential as somebody coming in.
Completely excellent question. So the way this plays out, this is pre-COVID, okay? So even pre-COVID, the average primary care panel would have somewhere between 50 and 75 touches per day. So we interact with somewhere between 50 and 75 per primary care provider team per day, but only around 10, 11, or 12 of those are in an exam room in our building. So the vast majority are phone, text, email, so forth. And one of the good things of COVID is the way we get paid in the fee-for-service environment, both including Medicaid and Medicare, has helped, right? We get paid better now for virtual visits and virtual connectivity. However, COVID primarily has resulted in the classic medical office visit being virtualized. So we still only get paid if it's like a comprehensive visit that's virtual. And, you know, the majority of our touches are not comprehensive visits as defined by payers. So, you know, at least half of what we do in terms of touches every day are non-reimbursed. However, back to that issue of margin, it is not just about revenue. If operating in this, we pay for everything, remember, we pay for the lab, we pay for the x-ray, we pay for the pharmaceuticals, we pay for the institutional treatment. We are comprehensive service providers between us and the tribal consortium. So we do save. If we do something that orders less lab, x-ray, and radiology and pharmaceuticals, we don't get the revenue, but we also do save on the cost side. So for us, it's about being comprehensive, vertically integrated, horizontally integrated, and making sure to drive down costs faster than revenue. But the direct answer to your question is 50 to 75 touches per day per panel, somewhere from 9 to 14 of them in person. Slightly more than that, though, are billable, because more and more of the virtual stuff is billable. I led an effort, a national effort during COVID called The Office Visit as a Dinosaur. So this was through the Institution for Healthcare Improvement Leadership Alliance. And there were 45 organizations across the country that signed up. And I was one of 2 faculty who helped lead this group through this work group for 2.5 years, called The Office Visit as a Dinosaur. And it was centered on this business of trying to weave products and services and knowledge into their lives on their terms, instead of having to have an office visit in order to interact with people. And it's fabulous, some of the work done out there, but I will tell you that 90% of the organizations that participated declared success by virtualizing the office visit, which I thought was a miserable failure of the goal of the work of the work group, because you need some visits, you need some virtual visits, and you need some office visits, but you need way more of all different disciplines being available, interacting, and like April was talking about, the way her teen children now interact with behaviorists and so forth, shouldn't have to require an in-person or even a virtual structured visit. So we got to get to risk-based contracting. We got to get to, you know, comprehensive payment methodologies where we get rewarded for these touches that then drive down total cost. And in Alaska, there's pitifully little, you know, payment methodology like that. We're still the great fee-for-service environment. In the tribal system, we do have this comprehensive daily rate for Medicaid, which is ultimately fundamentally cost-based. So we have an advantage over you and other people in that the way we get paid by Medicaid is to some degree cost-based. It's still, though, ultimately a transactional fee-for-service thing in order to get that money. And luckily in the country, we're sort of headed this way with ACOs and alternative payment models and so forth, but we're still a long, long ways from that being dominant. And in Alaska, we are well behind other places, as Preston, you know well, because the Providence system's very active in other markets where it is way much bigger pieces of the system. That was a long answer, sorry.
No, thanks, Doug, and 100% concur with where we need to be heading. So thank you.
Great. Drew is online with us, and he had sort of a follow-on question to that about essentially scaling to the population. And Drew, do you want to step in and pose that question?
Sure. I guess I'd be curious both in terms of overall dollars and maybe even more curious, particularly about types of providers. How does our capacity in the state compare with what you guys have for your service population? So if we wanted to scale your model to the state, how many more behaviorists and how many less x-ray techs or whatever else would we need to get there? Recognizing that there's a whole bunch of other things to transition aside from just getting the right personnel in place, but just looking for some scale comparison to, is this something where if we got there, we would be seeing a lot of savings, or would it be a bit more investment that we would be getting a lot more out of? Love the model. not sure how it compares with sort of our current model that everybody who's not your customers are using.
I'll, Drew, take a stab at that. I answered a little bit in the chat box, and then Doug can add to it. I think your question is spot on, right? So the idea is, what are we envisioning our future healthcare system to be? And are we growing a healthcare workforce to meet that need? I think in today's reality, we also have to ask ourselves if we are retaining a healthcare workforce to meet that need. I think that's a really important part of it, both with people leaving our field and also with the pull of folks who are really good clinically to leave clinical practice to do other things. So we need to create ways for people to grow clinically and as clinical leaders and stay in clinical practice to retain kind of that delivery system in healthcare. So that, your question wasn't so much about the retention side, but I can't help but say that we have to make healthcare a wonderful place to work. So stepping back from that, we also have to imagine our future healthcare system and how we grow the future workforce to meet that need. And your question is this nuanced. So if we are imagining this future, does it mean we need more of this and less of that? And I'll just back up and say, I think we're trying, but we haven't yet as a state even got into numbers that can make sense to future staff, any future workforce, right? I think we've got some really big gaps between how the staff we're going to need and the staff that we're growing today. And there's good work happening around that, but that focus is absolutely needed. Now, the way that I think our model helps us get there is by being less clinician focused and really creating space for people who bring their life experience, their culture and connection to community. And if you believe that the way that you influence the choices that we make in our lives, our day-to-day choices, what we eat, what we drink, how we parent, how we manage stress, that impact our wellness in the future, is by having trusted relationship. That's actually a lot easier with a community member who has a life experience similar to yours, rather than a physician that we recruited from out of state to come and work here. And so if we can think differently about who our providers are, right, who is actually delivering this care, and spread that out amongst more Alaskans, we can not only deliver a better healthcare system, but we can imagine actually staffing it in the future. Doug, do you want to add anything to that?
I threw a couple of things in the chat box, and I think you stated it super well. There are major workforce things. As I said earlier, recruiting from within the community, wish to influence. So it's not just the universities and so forth creating slots. It's also who gets to get into those slots. So, and this is true again for all communities. I applaud what Providence has done in identifying, for example, lead healthcare voices from the immigrant communities and other communities, and identifying them and paying them as important voices in this conversation, so that you don't just end up with those most able to compete for slots becoming the voices that you hear. We need to find ways for people from the communities we're trying to influence to also become the professionals and become the staff. And as April said, alternate workforce categories as well. And all of this needs to become a fabric. It's back to that business of, for chronic conditions, the doctor not being the rate limiting step, but just being one of a web of people who are involved in this process. So Drew, it's both supply and demand, but it's also changing what is the workforce and how do we actually do this work, and getting outside of the already determined medical categories that exist. And then one final comment. We were asked to provide a white paper to IHI about 15 years ago about the training of medical professionals in universities. And they were trying to find ways to entice more academic institutions to join the IHI club. Unfortunately, the paper we wrote basically said you need to blow up the whole damn system and start over. And so our paper was not chosen to try to entice academic institutions to join the IHI. But I do think there's an awful lot of truth there. How we choose our professionals and how we train them perpetuates almost all the problems of the current system in just terrible ways. And my wife and I moved across the street into a house. We rent out our house now to 5 doctors in training, one of whom happens to be our daughter. And thankful to Providence for the residency that she is participating in. But listening to those 5 doctors in training at different levels has been great for me, because it just reminds me of all the ways in which how we select people and then how we train them is massive brainwashing in the current medical model that is so fundamentally flawed for what it's trying to accomplish. Again, remember, for the 2/3 that's chronic illness driven, a lot of what we do in the 1/3 stuff, that's a lot of the hospital stuff and surgery and trauma, that's actually pretty miraculously amazing good stuff. We're talking about this other stuff, which is people living with chronic conditions, which unfortunately drives now the majority of the money in healthcare.
Okay, thanks. We are coming up on 9:30, and so I'm gonna.
Yeah,
go
but April and I are not out of words yet.
Oh, I know. I have the feeling that once you're up on step, you can go for quite a while on this. 2 to 5 days would be fantastic to have your time, but I know you guys have other things that you need to get off to. So I am going to turn back to Ralph for any closing commentary and offer our thanks. And before I do that, I will just mention that on April 5th, we do have a session with the folks from Matsu on the high utilizer program there. And we have some upcoming sessions, likely on April 14th on the 1115 behavioral health waiver with the Division of Behavioral Health at DHSS, or whatever we're going to call them from now on. And then a follow-up with the Alaska Mental Health Trust on the Crisis Now model. So look for those additional sessions in April. And so we'll turn to Ralph now. Ralph?
Well, obviously, I want to extend my deep thanks to both Doug and to April for taking their time to share their experiences with the system, with the Nuka system, with the broader audience. Certainly, the issue that there's a growing awareness that exactly the issue that Doug emphasized, that 2/3 of the cost of the care is driven by chronic disease management, and even a larger percent is driven by a group of folks who are dealing with multiple life conditions. And that is one of the focuses of this study group, and hearing the importance of a holistic approach as opposed to an individualized approach or single intervention approach, I think is a very important message for the group that we're working with. So again, thank you very much. We greatly appreciate your time and the energy that you bring to this important issue, for obviously for your customer members, but also for your for the broader population of Alaska. So thank you very much.
Thanks, everyone. Take care.
Thank you.